covering subdural and subarachnoid. From the beginning, I have to say that subdural hemorrhages and subarachnoid hemorrhages are not stroke by definition. They are labeled as a non-stroke presentation. Yes, so we are not dealing in stroke with subdurals and subarachnoids. So the content of the presentation is as follows. So I would like to outline, before to go into the TIA presentations and diagnosis and investigations and stroke, into the anatomy, a bit of physiology, how we should examine the CNS system, including, visual field defect to detect facial weakness, speech disturbances. I think this is going to build up and have a better understanding of, the presentations, and hopefully we could, with your help in the future, to reduce the amount of cases which are missed on admission. We still have such presentations. So as you know, stroke itself can be prevented, and acute and hyperacute treatment can have a major impact on patient outcome. Minor stroke and transient ischemic attacks are followed by high risk of early recurrent stroke. A stroke unfortunately happens every 5 minutes in England, and in UK is the third cause of death, and it's causing over 5 million deaths per year. We have this classification of 85% of total of stroke cases are ischemic and 15% are hemorrhagic. So what we know is that ischemic stroke is more often seen than hemorrhagic, which has good side and negative sides. A quarter from all stroke presentations are patients which are having recurrent repeated strokes. In UK, the length of stay was actually outlined in the last publication, 28 days, but we do tend to drop and to reduce the length of stay as much as possible. Shall we just go into anatomy quickly? I'll be as quick as possible, but if you have any questions, just stop me and I'm going back to the slide and I'm going to explain to you if you have the certain question. So we'll go to the blood supply of the brain, so arterial supply. We have the famous circus of Willis, which is an anastomosis, as you know, of at the inferior surface of the brain. It's formed by the two internal carotid arteries, right and left, and the two vertebral arteries. So each half of the circle is formed by, we have the anterior communicating artery.
Sorry, Dr. Constantin.
Yes, yes.
Oh, so, sorry, Dr. Constantin. I'm Kalyani. I was just wondering, are the slides supposed to be moving at all, or are you still on the starting slide?
Oh, sorry. Yes, please. Yes, please.
Oh, thank you.
Oh, thank you, thank you. Good.
Thank you.
Can you see my slide now?
Yes, we're on nervous system anatomy.
Good. Yes, we are. Yes, we are. So thank you for this. So this is what, I'm sorry about that. So this is what I was saying, that we have the circus of Willis, which is an anastomosis, a communication at the inferior surface of the brain. Is formed by the two carotids, and we have the two vertebrae, which are forming the basilar. So we have each half of the circus of the circle is formed by, we have anterior communicating artery, we have the anterior cerebral artery, we have the internal carotid arteries, which after that they are forming the middle cerebral artery each side. We have also the posterior cerebral artery and posterior communicating artery. It's a busy slide, but it's very simple once we understood It's very important in understanding the arterial supply, especially when we are planning investigations for our stroke patients. For example, if the patient has, for example, a stroke into the posterior circulation, which is basilar vertebral artery territory, we wouldn't explore, isn't it, the carotid or the anterior circulation for sure. So this is why understanding the vascularization is very important. And now we'll move to the posterior side. So we have the combination, so supplied by the end branches of the basilar artery. So this is how we have the pons, the pontine arteries. So we have the posterior cerebral arteries, yes. And also we have a certain area in the brain which is having mixed supply from posterior and middle cerebral artery. For example, circulation territories like thalamus. So posterior circulation is supplying blood supply within the occipital lobe, including the visual area and the temporal lobe. And also occlusion of the posterior cerebral artery is causing blindness in bilateral visual field. So this is why I'm saying it's very important to understand the circulation. Now we'll move to the venous system of the brain. As you know, venous sinuses are situated, are localized in the dura mater. We have is a system which is actually are devoid of valves and drain eventually into the internal jugular vein. We have a lot of venous sinuses. The most important are the first, so is the superior sagittal, this one. After that, the inferior sagittal, the straight, of course, and not the least the transverse sinus. These are the most often sinuses, venous sinuses, which are found to have fresh clots, old clots of venous sinus thrombosis. Moving forward, we have the meninges to understand the hemorrhages. So we have the three layers of the meninges. We have the dura, we have the arachnoid, and we have the pia mater. The space is, as you know, is extradural between the cranial or spinal bone and the endosteal layer of the dura mater. So this is when we have the extradural hemorrhage, the post-traumatic hemorrhage. And after that, the subdural space is between the dura and the arachnoid space. And this is where we have the hemorrhages post-traumatic after the following coagulation disorders or within anticoagulation treatment presence. And also we have the subarachnoid space, which is between the arachnoid and pia mater. And it contains a CSF and major vessels supplying the brain. This is why we could have hemorrhage in ruptured aneurysms or secondary to vascular malformations, so like arteriovenous malformations. We could have hemorrhage in this space, in the subarachnoid space, within hypertensive, uncontrolled hypertension, hypertensive patients, within coagulation disorder, or as well post-traumatic. So just briefly, I would like to discuss just one slide about the motor system, the afferent system, and sensory as well, just to understand how signals are going. So we have the motor afferent system. So we have fiber tract from the primary cortex. Remember the internal capsule. Internal capsule is an area where we have the fibers, motor fibers coming from. And this is why even when we have very small strokes within this internal capsule, we can have devastating, unfortunately, motor deficit. So patient is with complete hemiplegia. So fibers coming from internal capsule, as I said, are crossing over the pyramids, and they do descend towards the anterior horn of the cells in the spinal cord. And nerves ending in anterior horn cells are keeping in with the upper motor neuron. From the anterior horn down, actually ending into the muscles, we are talking about low motor neuron system. Just briefly, this is the homunculus, which I'm sure all of you know very well. But it's very important to have the homunculus representation in our mind, especially in localizing the stroke without an MRI scan on a CT, or to estimate. The sensory afferent is an afferent system, so it's coming from the peripheral, yes, and this is how the signal is getting into the spinal cord, brainstem, and thalamus, and eventually to the frontal lobe. Next one, so I'll try to be as brief as possible, but we have to go through the cranial nerves. There is no other way. It's just as a reminder, and I'm going to discuss about possible pathological situations which could interfere within that cranial nerve if it's involved. So in olfactory, so cranial nerve 1, as you know, the axons are forming from the olfactory mucosa in the nasal cavity, are passing the cribophane plate of the ethmoid and are ending up in the olfactory bulb. It's very important that actually this nerve, by having actually having the cuff of dura lined by arachnoid and pia mate, is actually a communication, is creating a potential communication and a route for infection between the subarachnoid space and the nasal cavity. This is how we could end up to have meningitis or CNS infections having the starting point from nasal cavity. The olfactory cortex is formed by the uncus and anterior perforated substance. So the bilateral anosmia, for example, is present in fractures of anterior cranial fossa. Unilateral anosmia is a sign of frontal lobe tumor. They're very typical. Olfactory hallucinations could be a type of fit. And very important, involuntary chewing movements with unconscious episodes could be a sign of tumor in the olfactory cortex. Second cranial nerve, so optic nerve. As you know, all the impulses from the rods of the and cones of the retina actually are going into the visual pathway, which is the optic nerve, the chiasma, the lateral geniculate nucleus, and the primary cortex, visual cortex. So the lesions of the retina or optic nerve, so over here or over here, we do have blindness in the affected segment of only one eye. So if it's before the cast, lesions of the optic tract and optic radiations are going to give opposite homonymous visual field defect. Also, we'll move to the oculomotor nerve, so cranial nerve third, which is having two elements. So one, the somatic motor fibers, which actually are the motor fibers which are supplying all these muscles of the eye, so the superior, inferior, medial recti, and the inferior oblique and the levator palpebral superioris muscle. So this is midbrain. And also we have the parasympathetic fibers which are supplying the ciliary muscles. Not the least, these are the pathological situations when we have the third cranial nerve affected. So it is presenting with diplopia, with ptosis, because of being affected the levatopalpebrae superioris. We could have the divergent squint with unopposed actions of the lateral rectus and superior oblique. We could have pupil dilatation, so mydriasis, how we are calling it in medical term, with unopposed actions of the dilator pupillae. Also loss of accommodation and light reflexes. The third cranial nerve could be actually palsy could appear in aneurysm of the posterior cerebral, posterior cerebellar, posterior communicating arteries because of its tract um, actually from and journey from the brainstem. Also, raised intracranial pressure secondary to any tumors, even in benign tumors like large meningiomas or inflammatory lesions in the sella turcica actually could give third nerve palsy. The fourth cranial nerve, the trochlear, is the smallest among all the cranial nerves, and we have somatic fibers which are supplying the superior oblique muscle, and what we have because of its place and actually track journey to the lateral side of the cavernous sinus. Actually, we could have the fourth nerve palsy, for example, if we have a dissection or if we have a tumor actually in this area. The fourth cranial nerve is going to give pulse is going to give double vision, especially the only when the patient looks down. This is why they could have, for example, difficulties walking downstairs. The fifth cranial nerve is the main sensory cranial nerve, and we have it's applying actually the mastication muscles. And we have also the four parasympathetic ganglia, and is distributed to the face, so sensory to the face, scalp, teeth, mouth, nasal cavity, paranasal sinuses, and most of the dura. Also is providing motor distribution to the muscles of the mastication, anterior belly of the gastric, and temporary tympani, tensor of palate. And not the least, ganglionic connection to the ciliary, sphenopalatine, otic, submandibular ganglia. Is a very complex sensory nerve and important. Uh, Six cranial nerve abducens. As you know, it's having motor fibers which are supplying the lateral rectus muscle, and it's important. It's another nerve which is emerges from the brainstem, and its journey actually is it enters the orbit at the superior orbit fissure and supplies the lateral. This is how it supplies the lateral rectus muscle. The seventh cranial nerve, facial, it supplies muscles, the muscles of facial expression. It conveys the parasympathetic fibers to the lacrimal gland, glands of the nasal cavity, submandibular, sublingual glands, and it transmits the fibers, the taste fibers from the anterior two-third of the tongue. Motor nucleus is located in the lower part of the pons, and from the pons, the motor fibers they loop around the cranial nerve force abducens, and this is how it forms the facial colliculus. The next one is vestibulocochlear, so the eighth cranial nerve, which is attached to brainstem, and at the level of the acoustic meatus, it breaks up into rootlets, which actually are piercing the thin medial wall of the vestibule, and they do innervate the maculae, the utricle, and the saculae. Glossopharyngeal cranial nerve, it contains, it's a busy slide, but you'll have these slides anyway. It contains the sensory fibers, which are including the taste from the posterior third of the tongue and oropharynx, and it supplies the stylopharyngeal muscles. It contains parasympathetic fibers, which are innervating the parotid gland, and it innervates actually the carotid sinus and the carotid body. We have a lot of this cranial nerve palsy, especially after carotid surgery, because by being so close to the carotid body and carotid sinus, actually it could be affected. So we could have a palsy of the ninth cranial nerve. Vagus is having sensory and parasympathetic fibers, and I don't want to, you know, the vagus, but it's very important that what we have in sensory fibers, these are actually controlling the sensation of the organs in the thorax and abdomen. And the parasympathetic, we have it innervates the muscles of the soft palate and pharynx and larynx, and this is what we can see, severe dysphagia due to the brainstem strokes, which actually are affecting the vagus nerve. Accessory nerve, so the 11th, is another one which is actually having the start point from the brainstem. And we have the two sides, the cranial root and the spinal root. The two branches, the cranial root, it joins the spinal root for a short distance, and then the branches are off to rejoin the vagus. Is distributed to the muscles of the soft palate, pharynx and larynx. So you can see that the 10th and the 11th cranial nerves are very much joined together. Spinal roots, spinal roots are originating from the upper 5 segments of the cervical spine. And they do join the cranial roots and leaves the skull through the jugular foramen. The hypoglossal is supplying all the muscles, extrinsic muscle of the tongue. And we have the somatic motor fibers, and also the nerve leaves the skull through the hypoglossal canal. Just briefly to mention the spinal cord. Spinal cord, it contains, extends from the lower end of the medulla oblongata, so from brainstem at the level of the foramen ovale, and this is how it's ending at the L1 level, or the upper border of L1, L2. The lower part of the cord is tapered to form the conus medullaris, which is a prolongation of pia mater, and is passing downwards to attach to the coccyx. The epidural space outside the dura, it contains fat and components of the venous vertebral plexus. A bit of physiology, and I'm not going to bore you too much before to start with the TI presentation. You know that the neuron is actually the unit, the fundamental unit of the nervous system, and it transfers information by using an electric signal, the action potential. Action potential are derived from changes in the resting membrane potentials of the neuron, which is about 90 millivolts, negative on the inside of the cell. This is something that we have to remember. And this is how we can understand the cerebral edema, by understanding this level of pathophysiology. And the reaction after an infarct or a hemorrhage within the brain tissue. So we have the resting membrane potential. How we are establishing this? We have a sodium-potassium pump transfer, so 3 sodium out of cell for every 2 potassium ions transported in. At rest, potassium ions are predominantly in the cell and sodium outside the cell. So an electrochemical gradient across the cell membrane is created with a relative negative charge inside the cell, as I said before. Each ion tends to diffuse down its own concentration gradient, but only to a point where the electrochemical gradient is balanced. When a nerve impulse is transmitted, the situation is reversed, and for about milliseconds, 0.5 milliseconds, the cell membrane is much more actually open to sodium than potassium. It's just what I want to mention here is how a depolarization happens. So a membrane potential becomes less negative as a result of sodium concentration influx in the cell at a threshold of around 60 millivolts. And this is how actually accelerating the influx of the sodium ions, we have the depolarization. The reverse potential is at around 45 millivolts. The potential and duration of the action potential is fixed. Moving away from action potentials and depolarization, we have the so-called refractory period. The absolute refractory period follows each action potential, so this is important to remember, and is a period during which a second action potential cannot be initiated. And how we have the propagation of the action potentials. So first of all, the depolarization spreads laterally to the neighboring area of the neurons and is resulting into opening of the sodium channels and initiation of the depolarization. So this process is speed up by increased diameter of the axons and also the myelin, which is increasing the membrane resistance and decreasing the capacitance. Depolarization is very important. It spreads from one node to the other, and at any one time up to 40 nodes may be involved in one single action potential. Very important is that local anesthetics such as lidocaine, for example, is able to reduce membrane permeability to sodium ions, which is reducing the chance of action potentials to be transmitted through the certain anesthetized area. And this is the mechanism of the lidocaine, for example. Synaptic transmission, I just want to say that we have the two types of synapses. We have the electrical and we have the chemical. Electrical are rare and allow the direct transmission of the current from the pre and to the postsynaptic neurons. The chemical synapse usually is a form of communication between the neurons. So we have the neurotransmitter release, and we have the receptor side and the postsynaptic potentials. And this is how actually we have the action potential arrives at the nerve terminal, is resulting into an influx of calcium. Within the nerve terminals, the chemicals, termed neurotransmitters, are found in these vesicles, which actually are recycled from the new vesicles. About the receptor sites, the postsynaptic potentials, we have an interaction between of the neurotransmitters, which is an appropriate receptor, which causes a local synaptic potential, which lasts longer than an action potential and can add up with one another. Is just briefly to understand the release of neuromuscular transmission, a release of acetylcholine, is that every action potential that arrives at the neuromuscular junction is followed by a muscle action potential. And we have around 300 of vesicles containing the acetylcholine, which are released into the synaptic cleft in the response of the increased calcium intracellularly. For example, in myasthenia gravis, we have the antibodies which are directed against the receptors, and the morphology of the neuromuscular junction is abnormal. So in the examination of the nervous system, it's very important to expose correctly the patient. Patient might or might not need, undressing, but definitely needs correctly exposed. General inspection is important to assess the higher cortical function assessment. I'll go through this. The cranial nerve examination and the limbs, upper lower limbs examination. So, for example, in inspection, it's very important to have the red flags, and very low threshold. For example, in MS, in multiple sclerosis, you have the speech very much bulb, pseudobulb, or you have the cerebellar signs, you have the eyes changes within examination, the nystagmus, you have the coordination changes, so cerebellar signs, you have the incontinence, so you can have the convene, either, catheter, leg back. In hemiplegia, you can have also, along with hemiplegia, speech changes. You can have the face asymmetry, the posture asymmetry. In spinal cord stroke or lesion, you can have the spasticity of the legs, and it is likely that the lesion is below the cervical cord level. In this case, is when we have the blood incontinence. In motor neuron, we have the bulb speech, we have the global wasting and the fasciculations. In Huntington, that we have the choreatetoic movements. In muscular dystrophy, the muscle wasting, generalized muscle wasting. In myotonic dystrophy, we have the myotonic phase, and we have the frontal balding and the ptosis. In peripheral neuropathy, we have the muscle wasting distally, and we have the ulcers in the feet, ankles, and with or without amputated toes. In Parkinson, the features. Patients are immobile, face is immobile, unblinking, with a typical posture of Parkinsonian, with tremor and general paucity. In neurofibromatosis, we have the typical skin changes with the café au lait spots. So the high cortical function, what I meant, this is called sequin in our Clarkin Proforma, and each trust in UK has it. And is the general screening to check if there is confusion, any altered changes in their state. So moving towards the cranial nerve examination, very important. What I realize is that we do not examine, after establishing patient GCS. I think we should concentrate on the pupillary examination and to shine the light to check for the pupillary defect. So I hope you could remember when you are doing the next neuro examination. And yes, eye movements are very important. We can have ptosis, as I mentioned earlier, in the Turner palsy with complete or partial Horner syndrome. So we could have the pupil smaller. So in any case, when you have the ptosis and pupil is smaller, just have a low threshold for possible Horner syndrome. So very important is to so examining, like asking the patient to actually hand on the forehead of the patient, and ask the patient to follow your finger. And this is how you are checking for diplopia, or cover one eye. It's not wrong either way. Just make sure that you are examining. Typical for brainstem and cerebellar disorders, having the saccadic horizontal movement, so the nystagmus, horizontal nystagmus. Fundoscopy, it might or might not be done, especially in stroke, but you have a general neuro patient, you should do fundoscopy. So this is how actually the eye movements are in third cranial nerve. So on the left in this picture, yes, so you have the droop of the eyelid. Yes, the patient is looking downward or sideward. This is just a quick picture to remind you of the nerve pathways for lateral gaze. So you can see that in lateral gaze, you have the 3 cranial nerves involved, so the third, the fourth, the sixth. And very important, one of the presentations and findings on our examinations in posterior circulation, so in brainstem strokes I'm talking about, is internuclear ophthalmoplegia. So let's concentrate on the right-hand side image. So this is how the pupil the eye supposed to look, the right, the left, normally. So the patient is having gaze to the left, and you can see that actually both eyes are moving towards the left. But when the patient is, for example, asked to look at the right, actually you can see that the left eye actually is not doing the movement, so it's losing adduction. So this is typical actually internuclear ophthalmoplegia, and actually is a palsy of the abducens of the sixth cranial nerve. How we are examining sorry, uh, I said the trigemin here is actually you could we just with fingertip, you could the pain sensation with pinprick. We are not really doing it. Um, corner reflex, yes, and we can see the wasting mastication muscles. But just by stretching, bilaterally, check bilaterally, and also avoid stroke motions. um, uh, Very common causes for the trigemin abnormalities. So when we have a unilateral loss of the sensation in one or more branches, we could have due to infections like herpes or injuries like facial fracture. Loss of corneal reflex within the three cranial nerves, third, fourth, and sixth, because of their anatomy, appears in lesion of the cavernous sinus. Also, brisk jaw jerk is present in bilateral upper motor neuron lesion above the pons. We will come back to upper and motor neuron just to distinguish between the two. Facial nerve, asking the patient to examination, is to wrinkle forehead, to show teeth, to blow cheeks. As I said earlier, it supplies space to the anterior two-thirds of the tongue. And weakness of the upper and lower facial muscles. For example, in upper motor neuron is affected by Bell's palsy. Sorry, low motor neuron disease, lesion, Bell's palsy, surgical injuries, or Ramsay-Hunt syndrome. And weakness of the lower face muscles in upper motor neuron lesion, so stroke. It's very important to distinguish between the two, as we have plenty of cases. Bell's palsy is still less and less is true, referred to us as possible stroke, especially from A&E and community. Nervous system examination to continue. So we have the eighth cranial nerve, vestibulocochlear. So we have at least to check, and especially with pre-grads, with medical students, we are doing this. We are doing less and less in general neuro examination because of the time consuming. But we have to remember that the examination of the vestibulocochlear is to cover one ear by pressing on tragus and to whisper. Generally, this is what we are whispering 7, 8, 9 into the other. If hearing is normal, we can move to the next cranial nerve, but if it's abnormal, we have to do the Weber and Rhines test. And Rhines test is to hold the tuning fork on the mastoid until no longer it's heard by the patient, and then to hold by the external auditory matters. Weber's test is to place the tuning fork on the vertex, and it should be heard equally in both ears. And yes, we have the conductive deafness and the sensory neural deafness, especially remember in acoustic neuroma, we have the sensory neural deafness very often seen. The conductive is generally in within the local obstruction by wax, or we have the membrane damage, or we have the head injury with small bones damage, and also in otosclerosis. and the glossopharyngeal and the vagus. So I don't want to insist on this, but the vagus should be checked by asking the patient to repeat certain words like yellow lorry, also while saying a long ah, to make sure that we are checking on palate movement, to make sure that palate is centrally aligned and is not deviated to either side. We are not checking on pharyngeal sensation and gag reflex. These are tests which generally are done by the speech therapist if it's the case, if it's required, not on each patient. Spinal accessory cranial nerve examination, it's actually by inspecting and palpating the sternocleidomastoid muscle. So we have to make sure that it's symmetric and is not wasted. The test, we have the test strength. So to ask the patient to twist their neck to the right side as you resist the movement by placing the flat of your hand on that side of their face, and of course repeat in opposite side always, so bilateral examination. Very isolated in palsy of the 11 cranial nerves, so spinal accessories, is in post-surgically, especially we have tumors of the triangle, posterior triangle of the neck, and also in dystrophic conditions like dystrophia myotonica, we have muscle wasting of the sternocleidomastoidean. The hypoglossal has to be checked, and we are checking it by asking the patient to open mouth, checking for any of the following: wasting of the tongue, muscle wasting, fasciculations, abnormal movements of the tongue. And patient is asked to stick the tongue out and wiggle it from side to side. We are searching for any asymmetry or protrusion. Also, we do test the test power by asking the patient to press with their tongue against the inside of each cheek in turn, while you are pressing from the outside with your few fingers. So visual defect, we have the visual defect could be a feature of acromegaly, could be a sign of stroke. And we do have, very important is to have the visual, the aids for those with visual field, visual impairment, either, white stick, magnifying glasses, or braille book. Now that we clarified the anatomy, we clarified the examination, we are moving to the features, the presentations of how a stroke could present. So we could have episodic headaches. In headache presentation and descriptions, imagine like in chest pain description, when you have a cardiac chest pain, what are the features? So same way for headache. So for example, we have a referral, frequent severe headaches. We have a teacher with no past medical history who's on regular codeine, but the codeine is actually not really controlling the headaches. Patient is with normal examination, and we have normal blood pressure readings. So I don't think that the history alone is going to help in clarifying the nature of the headache or the type of the headache. Very much it's correct that incorrect diagnosis is caused by in an incorrect history. So history is giving us 50% of the diagnosis. So when you have a headache presentation, we have to clarify if the headache is benign, and if it's benign, what is the cause. So very important is to exclude life-threatening conditions like raised intracranial pressure secondary to any of the following. So space-occupying lesion, including a hemorrhage or a large infarct, hydrocephalus, or even an idiopathic raised intracranial pressure, less often systemic condition. So it's very important to have these points, the following points, which I outlined here. So for how long the patient had the headache, how often is having the headache, is the headache localized, what is the character of the pain. So pain could be a shooting pain, a pressure like, a stabbing like, and what does the patient do during the attacks? Are there any aggravating factors? Are there any associated features? Very important is to clarify the medication at present, and was there any medication changed before? Yes, it's important to understand that if there is any history of depression or use of tetracyclines or steroids or vitamin A. Pregnancy is important. We'll have different approach in pregnancy and headache, along with neurodeficit. Very important to clarify history of background of autoimmune disorders, deep vein thrombosis, contraceptives, weight gain, head injury, or CNS infection, meningitis, which are increasing the risk of hydrocephalus. So the red flags which we have in our practice, we should use in our practice are the following. So subacute onset of headache with steady progression over days or weeks. Also a recent change in the pattern of a known long-standing headache. For example, if we have associated fever or other systemic features, or if we have focal signs along with papilloedema, personality changes, or seizures, all these could raise suspicion of space occupying lesion or other central cause. And also when we have a new onset of headache in patients above age of 50. So this is when we really have to image the patient and to make sure that we have at least a head scan. So what we are doing generally, what is the management in headache presentation? If it's isolated headache, so there are no other neurodeficit, we should explore the blood test, ESR and CRP. Does anyone know why in headaches we are doing ESR and CRP? No? Are you typing? Okay.
To rule out
So,
fibromyalgia rheumatica.
yes, very well. Good. Well done. I don't know who said it, but well done. Also, as I said, at least a brain imaging, a plain CT head scan. Generally, they do end up to have an MRI, but CT head scan is important before the lumbar puncture. So make sure you have these patients very often, especially when you are on call in acute medicine. Make sure that you are imaging the patient with headache presentation. And yes, we can even repeat the lumbar puncture management-wise. And generally, these patients are ending up in neurology clinics rather than to be seen by us. When you have facial weakness presentation, always is a battle, is this central or is peripheral? So very important, as I said earlier, we have the upper motor neuron, yes, and we have the lower motor neuron, and this is the difference so between the Bell's palsy and the central cause, the Bell's palsy peripheral cause. Remember. So facial weakness, how we explore this. So if it's unilateral, is due to low motor neuron. And for example, sixth cranial nerve palsy is affected in isolation or opposite to Pons lesion. Very important is to remember that facial nerve palsy, in facial nerve palsy, we have head and neck has to be very, very carefully examined for mass tumors for scars, because we can have ear surgical removal or cerebropontine angle tumors removed. So as I said earlier, we have the upper motor neuron, which is any process at the level of the facial nerve impons. We have to remember that the cerebral hemispheric lesion results in the opposite upper motor neuron sign, affecting the face and the limb. Bilateral face palsy, myasthenia gravis, for example, we have the fatigable weakness with complex ophthalmoplegia, with lack of sensory signs. In myotonic dystrophy, we have the check for the grip and percussion of the myotonic. And very much in bilateral, in Guillain-Barré, we have bilateral face palsy, very sudden, so it's acute, recent. How we are checking the speech, for example. So in dysarthric patients are when we have a disorder of the articulation. So the content of the speech is unchanged. Aphasia or dysphasia is a disorder of the gauge caused by a cortical lesion of the dominant cerebral hemisphere. Dysphonia is a disorder of the voice production, but the articulation and the language in dysphonia are normal. It's very important to remind ourselves that we can have vocal cords damage in neck surgery. For example, in our specialty, we have the carotid surgery, the endarterectomy, when actually post-surgery we can have the vocal cords unfortunately damaged, very rarely, but is one of the possible complications. And even in the first few days after the surgery, because of the swelling of the neck, of that area, a patient could have actually temporary um, uh, changes in the speech. So is actually more dysarthria, could be more, a bit of dysphonia, which is transient. So what are the type of the speech changes? So dysphonia is the hoarseness of the voice, which is typical in brainstem stroke. Dysarthria is can appear generally in any type of stroke, any territory. Cerebellar speech is very typical because we have an uneven, irregular output, but generally is not on its own, so it's associated with other cerebellar signs. Generally, we should have some ataxic gait. Pseudobulb or spastic dysarthria in bilateral lesions in upper motor neuron are associated with changes of the swallowing, so dysphagia, a bit of spasticity of small spastic tongue, and brisk jaw jerk. We can have also affected the fluency of the speech. So with normal phonation, normal articulation, but if speech is not fluent, could be actually a motor aphasia in Broca's lesion. So now that we opened I touched the base with Broca. So in Broca lesion, so we have the speech is presenting with expressive dysphasia. Yeah, so patient is understanding but is unable to express himself. In Wernicke lesion, Wernicke speech is when we have the global aphasia, so patient is unable to understand and to express himself. Yes, we can have changes, especially in temporal lobe stroke. We can have naming difficulty, is called anomia. We can have repetition of the speech, so patient is repeating himself with the same answer, especially in Wernicke. So patient is replying to yes with yes to everything. And yes, we can have the sensory aphasia in reading, and we can have motor aphasia in writing. So yes, we can. We have, as I said earlier, the motor and the sensory dysphasia. How should we approach acute paraparesis? Remember that stroke could happen within the brain, but stroke could happen within the spine, cervical spine too. And acute paraparesis is critical. It is critical that acute spinal cord compression has to be considered. Actually, you could save the patient's life by having the right approach. In acute phase, it's very difficult to make a clear diagnosis if it's upper or lower motor neuron. History and examination are going to drive you between the acute cord syndrome, acute neuropathy, or peripheral muscle disease. Just to make sure that I wanted to send this message that in Guillain-Barré we have the ascending symptoms, as you know, preceding the illness, with the preceding illness, so the infection, which could be presented with diarrhea or viral respiratory infection. Back pain may point to the vertebral bodies or discs. And yes, cranial nerve signs associated are going to point the brainstem. So finally, transient ischemic attack is, by definition, the traditional definition is implying that is the episode of acute loss of focal cerebral or monocular function lasting less than 24 hours. I'm going to desiccate this definition further down. It's caused by insufficient cerebral or ocular blood supply as a result of an arterial or cardiac or hematological cause. So the definition is actually tissue-based rather than time-based. So what I want to state with this that we can have episode which is lasting 4 hours, which is going to have an MRI changes on the certain sequence DWI. And we could have, for example, in which case is a stroke. And we could have presentation which is lasting 6 or 8 hours, repeated episodes within this time, and the MRI could be normal. So this is why I'm saying that definition is rather based on tissue damage, which is picked up by MRI. We do not tend to do MRI head scans in TIA presentations, but just an MRI head scan could clarify if the presentation, which lasted less than 24 hours, was a TIA or a stroke with normal CT scan. 1/3 of the TIA presentation is defined by the 24 hours criteria, have an abnormal MRI head scan. What is the presentation? So we have the carotid presentation, so the anterior circulation, which is actually presenting with contralateral, so opposite side of hemiplegia, so we can have paresis or heaviness or clumsiness. It could affect the face, the arm, the leg, with sensory deficit of the face, arm, or leg, or all together. It could present in carotid presentation with unilateral, so same side, ipsilateral visual field loss. It could give changes in the speech, like speech loss, dysarthria, and also we can have any of the above combinations. In vertebrobasilar TIA presentation, we could have unilateral or bilateral or alternating paresis. We could have sensory loss, unilateral or bilateral. We could have double vision, diplopia. We could have visual field loss, we could have dysphagia, so swallowing, transient swallowing difficulties, dysarthria, or any of the above combinations. Very important is that non-focal symptoms like loss of consciousness, like dizziness, so isolated, yes, or mental confusion, or generalized weakness, like, sometimes patients are stating, I feel generally weak, or incontinence. These are not TIA presentations. So we do have to have focal symptoms. So what is the approach in the TIA presentation? Very important, the cardiovascular examination. I just want to make a note that in subclavian still syndrome, which could be brought up by, especially in middle age adults, is brought up by exercise of, we can see the subclavian still syndrome, and is brought up by exercise of the ipsilateral arm with stenosis of the proximal subclavian artery and aortic arch, which of course is leading into retrograde flow down to the vertebral artery. So what we have clinically, we could have reduced blood pressure and pulse in that arm. So this is typical for subclavian still syndrome, which actually is giving TIA presentations. So we do the CT scan as an investigation, the carotid Doppler, at least a basic ECG in the first instance, followed by further cardiac investigation, so prolonged Holter ECG and echocardiogram, but echocardiogram just if it's needed. Also, vasculitis screen, with or without thrombophilia screen. We do tend not to do thrombophilia screen after age of 50. Also, the medical treatment is implying dual antiplatelet, so the aspirin along with the clopidogrel for 3 weeks, and after that to continue with clopidogrel only. In the case, so this is the medication, the treatment, in the case that we don't have the anticoagulation need either for atrial fibrillation, multiple embolic events like PEs, DVTs, metallic valves. So we wouldn't load the patient with dual antiplatelet and therapeutic anticoagulation. Also, it's very important to have the secondary prevention, so lipids control, blood sugars control, so diabetes control by having the HbA1c screening test, and yes, the blood pressure control. Very important is that in TIA, you'll notice that we are actually stopping patients driving. Is different. DVLA recommendation is different. If the patient had a single episode, it's going to be driving cessation for a month. But if we have 2 or more episodes with negative MRI head scan, will go for 3 months driving cessation. So stroke itself, it's producing, unfortunately, affecting, actually not producing, affecting quite a lot of patients within UK. Is considered that is the 4th single largest cause of death and is 2nd cause of death worldwide. So we have around 1.2 million stroke survivors in UK, and as you know, is a presumed clinical syndrome caused by vascular origin. And actually, it can present with a rapid developing symptoms. We are talking about acute, hyperacute symptoms. So stroke symptoms are not going on over weeks or months. We are talking about stroke symptoms going on over minutes, no more than few hours. And very important is that we have symptoms and signs of focal at a time, global or loss of cerebral function, which is lasting more than 24 hours, could last more or up to 24 hours. And yes, it can lead to death. So as a classification, we have the ischemic cause, when we have a cardioembolic cause due to possible large vessel atherosclerosis, small vessel thrombotic disease, embolic from cardiac source, or cryptogenic stroke when we don't know the cause. And also we have the hemorrhagic stroke, primary or secondary, and I'm going to come back to this. In hemorrhagic stroke, thrombosis is actually relying a lot on the so-known Virchow triad, as you know, the large vessel wall abnormality in atherosclerosis, in dissection, in vasculitis, small perforating vessels due to lipohyalinosis, and blood abnormality, as you know, polycythemia. And yes, blood flow disturbance like AF dissection could be another mechanism. The formation of the clots, clots could have two different types. We could have the platelet type of clots, generally in fast flow areas like internal carotid arteries with these atherosclerotic plaques, or we could have the fibrin and red blood cells clots, especially which are sourced from cardiac atrium in atrial fibrillation, for example. Very important is to control the cardiovascular risk factors, and I don't want to bore you here, but the cardiovascular risk factors to be controlled and strictly controlled are important. So it's important to evaluate them. So starting with hypertension, with smoking history, with heart failure, ischemic heart disease, diabetes control, and so on. What is the pathophysiology in stroke? So we have reduction of the cerebral blood flow of less than 50 mL per minute per 100 gram tissue leads definitely to cell death, so irreversible changes within the brain unless this is reversed. Also below 20 mL per minute per 100 gram, it's implying loss of electrical function, which is reversible, and irreversible damage below 10 mil per minute per 100 gram is equal to necrosis, so cells death. So classification of the stroke, as I said earlier, we have the arterial stroke and we have the venous stroke. Luckily, the venous stroke is less often seen among the vascular system. When we have the infarct, we have the two big types of the ischemic stroke. We have the anterior stroke, so-called carotid circulation related, when we can have the total anterior circulation stroke, which actually is less often seen among the anterior circulation strokes, but is the most damaging. So luckily, it's less often seen. It's affecting among 15% of our stroke patients. The partial anterior circulation stroke is affecting double patients compared with the previous type of stroke. And 20% of the anterior circulation strokes are lacuna strokes. The posterior circulation stroke is within the vertebrobasilar system and is covering around 20% of the strokes. But these are the type of strokes which are having atypical presentations and most often missed, unfortunately. In hemorrhagic strokes, by definition, we have the intracerebral hemorrhages. Yes, for example, in states, subarachnoid hemorrhage is considered stroke. Unfortunately, in UK, we do not consider subarachnoid hemorrhage a stroke. Moving forward, in ischemic stroke is the fourth single cause of mortality in UK and is the leading cause of long-term acquired adult disability in most countries. is the most common life-threatening neurological condition, and it's responsible for around 5% of the NHS whole budget. It's actually covering 85% of all strokes. Prognosis could be poor, and up to 20% of ischemic stroke patients die within the 30 days after the first in a lifetime stroke. Risk of dying following the stroke is highest immediately after the event, and then falls over the next few weeks and months. Although the risk of dying in the year following the stroke remains quite high compared with stroke-free individuals. Outcome can be improved by recognizing as a medical emergency and act quickly. And I'm going to tell you how to act. So very important is to take the right history. So to clarify that the presentation started suddenly, that the patient presentation is hitting the maximum within minutes, no more than hours, and we have negative symptoms. So loss of speech, loss of power, loss of strength, loss of sensation. Risk factors, as I said, they are, yes, we outlined them already, but just to mention that they are modifiable and non-modifiable. And the modifiable ones we have to insist, so control of the hypertension, diabetes, dyslipidemia, cardiac arrhythmias like atrial fibrillation, obesity. And now the examination, yes, is covering, the airways, the GCS, the vital signs. Yes, you have to check for the neck stiffness. You have to exclude CNS infection, and not the least signs of atrial fibrillation, of cardiac valve disease, of heart failure, and carotid bruit. Neuro examination is important, but has to cover cranial nerves, motor, sensory, tone, reflexes. I could argue here in acute ischemic stroke, reflexes are not really useful. Coordination, definitely, sensation, speech, and cognitive examination, exactly what we discussed before. The standard imaging is plain CT head scan initially, along with the blood test, covering full blood count general screening, including inflammatory markers and lipidogram. Chest X-ray could be useful, especially when aspiration is quite often seen. ECG, plain ECG. MRI head scan, it's useful, but generally we do not do this on admission. So MRI head scan could be needed or not later on throughout the admission. Echocardiogram also is not a must, but I outlined it here as it's useful in certain situations, especially when, for example, the patient with an embolic stroke is having a PE as well. Also in valvulopathies or new murmurs. So ECG monitor is required, and carotid Doppler or angiogram. And I'll tell you the when we need the one and when we need the other. So carotid Doppler generally in patients which are they have a non-disabling stroke, so patient can mobilize in a way or other. And CT angiogram generally is done on admission in acute setting when the CT head scan is not showing a bleed, is excluding a bleed. So what I wanted to outline here is, for example, the difference between the CT and MRI. On the left-hand side of the screen with the arrow, you have a CT image, and you can see that this is the whole right hemisphere. So this is the right middle cerebral artery territory, hypodensity, which is actually a huge infarct. So this is very much is going to give total anterior circulation stroke. Patient is going to be fully dependent with left hemiplegia, isn't it, with speech and swallowing function severely affected. And also this is the difference, for example, in how important and how delicate and precise is the MRI head scan, which is having very pretty pictures. Yes, I mean, we would go for an MRI head scan when the patient is having um, uh, uh, stroke features and the CT head scan is normal, of course, if it's possible and there are no other contraindications. So what is the treatment? And this is now when you are going to understand why I mentioned the CT angiogram done in admission in acute setting. So based on a CT head scan, we have excluded the hemorrhage. Intravenous thrombolysis is one of the hyperacute treatment options when we have a clear cutoff onset within 4.5 hours from the start of the event. And when I'm saying with no contraindications, we have a long list of contraindications, and this is like a checklist on our thrombolysis pro forma, and is implying to exclude, for example, any DOACs if the patient is on. For example, if the INR is more than 1.7 on a patient on warfarin, or recent surgery, or any bleeding disorder or bleeding history. So intravenous thrombolysis is one treatment option. Mechanical thrombectomy is another treatment option, which we can't provide here in Lincoln, but is provided in locally for the whole region in Nottingham. This is could be offered based on a plain CT head scan and a CT angiogram. So knowing that the CT head scan excluded hemorrhage, so it's hemorrhage free, and the CT angiogram aortic arch carotid head is actually picking up on a large vessel occlusion. Yes, the CT angiogram is useful in these situations, even in wake-up strokes. So in up to 24 hours from the event, generally, it could be even beyond the 24 hours. What is the medical treatment with or without thrombolysis? So 24 hours after the thrombolysis and 24 hours after mechanical thrombectomy. This being said, that the follow-up repeat head scan excluded large hemorrhage as a complication of the two treatment options. Just before I'm moving on from here, we could offer thrombolysis along with mechanical thrombectomy, or, any of the two treatment options individually, separate from each other. What evidence we have is that patients which is thrombolized and having mechanical thrombectomy, when indicated, they have a better outcome than just with thrombolysis, for example. So the specific treatment based on the new guideline is actually followed by the aspirin, 300 milligrams a day, standard for 2 weeks, and followed by clopidogrel. In mild stroke, so which are not covered here, in mild stroke we can have the dual antiplatelet exactly like in TIA. This is what the present guideline states. For 3 weeks, and after that, single antiplatelet clopidogrel long term. Very important in acute stroke generally, but I'm talking about ischemic stroke here, is to check on swallowing function. So every single suspicion of stroke patient supposed to be nil by mouth. As doctors, we are not allowed to check on swallowing function. So we have actually dysphagia trained nurses, so stroke nurses or stroke ACPs, along with the speech therapist, which could check on these patients. For example, I'm not allowed to check on swallowing function of a patient. Also, hydration is important in these patients, and to start to feed as early as possible. So I'm talking about oral or artificial feeding. Hypertension management, so we do tend to interfere in hypertension, especially when we are thrombolizing. So we can't thrombolize someone with 200 blood pressure. So we have to have, for example, systolic below 185, but not higher. But generally, in ischemic stroke, we are not invasive apart from thrombolysis to lower the blood pressure. Yes, BM control is important and to lower blood sugars if is the case. VT prophylaxis is very important. Stroke team could decide if we need the mechanical actually version, so floatrons or intermittent pneumatic compressive stockings, which are actually the standard treatment for prophylaxis in ischemic stroke as per the stroke guideline, but also the alternative is low molecular weight heparin, which the dose has to be agreed with the stroke team. So generally what we tend, if the IPCs are contraindicated, because of certain things, for example, pedal edema, chronic leg ulcers, or suspicion of a fracture, lower limb fracture. This is when we can use the low molecular weight heparin, but adjusted dose. So, for example, if patient qualifies to have a 40 milligrams of enoxaparin, is going to receive 20. But it's better this to be decision to be run with us. And yes, rehab. And when I'm saying rehab, is a joint stroke MDT, so it's covered by physiotherapy team, occupation therapy, speech therapist, and dietitian. What are the complications in ischemic stroke? So cerebral edema is the commonest cause of death within the first 5 days after the onset of the stroke. Hemorrhagic transformation is another complication which is generally expected, especially in large size of strokes. We could have hemorrhagic transformation within the core of the stroke. Seizures actually could appear in up to 10% of the strokes, short term and long term. Any stroke anywhere in actually in the brain could cause seizures, especially frontal, temporal lobe. But we've seen even in brainstem strokes causing seizures. Also, we could have SIDH in the first week or so after the onset of the stroke. Yes, pressure source is a often complication, especially in elderly patients, despite of the special care that they have, being turned each 4 hours, day or night. Venous thrombosis or any venous thrombosis is due to the reduced mobility despite of the VT prophylaxis. This is why the VT prophylaxis is very important to be given to lower this risk. Yes, we can have infections. Aspiration is more often seen, but we can have UTIs also. And yes, mood disorders or depression, very often in left hemisphere anterior circulation stroke, we have around 50% of the stroke cases. So we are talking about dominant hemisphere, frontal lobe strokes. In subarachnoid hemorrhage, because the topic of the presentation is covering it, I'm going to discuss briefly, and I'm talking about. I would like to insist in regards with the non-traumatic subarachnoid hemorrhage, which is covering around 80% of the presentations and is caused by ruptured of the Berry aneurysm, which is located at the arterial bifurcation along the circus of Willis, and could be caused by AVM, so arteriovenous malformation, by arterial dissection, could be caused by cerebral amyloid angiopathy, by venous sinus thrombosis, and hypertension. So the common sites of the aneurysms are actually in the anterior circulation, as you can see. So we have anterior cerebral artery 35%, MCA 20%, the bifurcation of the internal carotid artery and PCA 30-35%. Less often in posterior circulation, you can see the basilar artery bifurcation, just 5% risk of site of aneurysm, which is good in the way that, for example, basilar artery aneurysm hemorrhages are generally life-threatening. So it's good that actually we have less aneurysms as a site anatomically of these formations, which actually could develop during the course of the life. So we are not born with this vessel malformation. So this is how, for example, subarachnoid looks like. On the left-hand side, we have actually a CT head scan, and you can actually see how the blood is filling in all the subarachnoid systems, and actually how the lateral ventricles are actually suffering by having enlarged temporal horns bilaterally. And actually, we have trace of the of blood in the ventricle. On the right hand side, we have in the A slide, we have this is the MRI head scan images, which are actually with the black arrow. You have the rim with dark pointing out that this is actually a small subarachnoid hemorrhage. And also on flare, we can see actually a very small rim with the white arrow of subarachnoid. How do they present and what is the prognosis briefly? So unfortunately, 30% of subarachnoids are misdiagnosed, and you'll understand why. First of all, we do have, they could present with anything. They could present from very much strong headache. Patients do present like, they do state that is the worst headache ever, up to impaired level of consciousness when actually the patient is getting into a coma. And yes, we could have just seizures at the presentation, we could have drowsiness, we could have neck pain or nausea and vomiting, back pain, or we could have some focal neurological deficits, so weakness or speech difficulties or acute confusion. Very important is that when we have reduced impaired level of consciousness or coma at the presentation, this is a very bad prognosis. I just want to say that the severe headache with nausea and neck stiffness presentation, generally we do concentrate on CNS infection, isn't it? Or we do concentrate on migraine, but we shouldn't forget about the subarachnoid hemorrhage. Prognosis after subarachnoid hemorrhage is poor because we have a mortality of 40% in the first 24 hours if we have a ruptured aneurysm, which we could actually lower by referring these patients based on CT head scan to the neurosurgical team, and based on the CT angiogram head, the aneurysm could be actually spotted, and patients could have actually clipped aneurysm to improve the outcome. Another 25% will die with complications within 6 months. Actually, subarachnoid hemorrhage patients could actually turn for worse in the first 30 days after the bleed happens. So how do we examine these patients? So basic, so we'll do the ABCD, very important, the GCS, vital signs. They do present generally with high blood pressure. So the highest blood pressure that I witnessed in my practice was actually 250 systolic in a young adult. He was early 20s with subarachnoid hemorrhage, non-traumatic, so was ruptured aneurysm related. Yes, neck stiffness examination for it's useful. Yes, we have to exclude signs of head injury, hypertension, alcohol, drug abuse. Neuro examination has to cover the cranial nerve examination with fundoscopy. We are searching for papilloid edema, for retinal hemorrhage. If it's possible, visual field to be checked and pupil responses, which are going to be absent in hydrocephalus. Eye movements are important, so we'll have the third cranial nerve palsy in ruptured aneurysm of the PCA, ophthalmoplegia in brainstem, and also bilateral sixth nerve palsy in increased intracranial pressure. Yes, it can present with hemiparesis or cerebellar signs, especially in vertebral artery dissection. And what are the standard investigations? So standard blood test, at least an ECG, a chest X-ray to explore the possibility of aspiration. CT head scan is quite is a very good test actually, and is investigation of choice. We've been using CT for so long, but plain CT head scan is actually having a quite high sensitivity. You can see 98 to 100% within 12 hours of onset, and 93% so dropping sensitivity within 24 hours. Lumbar puncture is useful, and in your practice you notice that this is the approach, especially when the suspicion is high, but we have a negative head scan. And xanthochromia, generally a test is negative within the first 12 hours. This is why we should wait for lumbar puncture, should be done after 12 hours if there is suspicion of subarachnoid hemorrhage. And yes, we could do further investigation, so forms of angiogram, digital subtraction angiography or CT angiography, but this, for example, DSA cannot be done in Lincolnshire, so this is a tertiary center. If there is a suspicion of an aneurysm which was not detected on the CT head or CT angiogram. Yes, CT angiograms can be done in Boston and in Lincoln. So what is the management in subarachnoid hemorrhage? They do have to be highly monitored. Very important to have bed rest and hypertension management. Nimodipine is a very specific measure, can be used only if patient is not hypotensive. So we have the 60 milligrams 4 hourly of orally, could be given as an intravenous infusion, especially if patient is nil by mouth and treatment has to be started and we don't have an NG tube to start with. The endovascular treatment of aneurysms generally is coiling, which is done on the neurosurgical team. Generally, indications for coiling for the clip of the aneurysm within surgery is if we have a high GCS higher than 12, or if we have Glasgow Coma score less than 12 with space occupying lesion. So we have intracranial hemorrhage or hydrocephalus along with subarachnoid. Immediate surgery for hematoma evacuation is possible, indicated if we have a large intracranial collection of blood and if the patient becomes increasingly drowsy. Long term, very important to have the vascular risk control, risk factor control. Driving has to stop for 3 months if the patient had full recovery, which we have cases. Complications, most often complications after subarachnoid, delayed cerebral ischemic actually event secondary to vasospasm, and this happens generally when the clip or coil is applied endovascularly or surgically on that aneurysms, and this is when they can develop due to the vasospasm ischemic stroke, and this is when these patients are coming on our way. Yes, they could have rebleeding. It's stated that 50% of patients with subarachnoid hemorrhage are going to have another bleeding after the first event. And hydrocephalus is another complication which unfortunately needs early ventricular drainage, neurosurgically, of course. Now the intracerebral hemorrhage. So luckily they are covering just up to 15% of all strokes. They are twice more common than subarachnoid. We do have in primary hemorrhagic stroke, main causes hypertension and amyloid disease, cerebral amyloid disease. In secondary hypertension, less often seen, but still as a cause, we have the oral anticoagulation, which you can see in your practice that are more and more used for good reasons. Could appear in underlying bleeding disorders, in tumors, primary or metastatic tumors, in ruptured aneurysms, in vascular malformation, so arteriovenous malformation, in cerebral venous thrombosis, in cerebral vasculitis, in sympathomimetic drugs or eclampsia. Chronic hypertension gives, unfortunately, vasculopathy within the small perforating arteries, causing lipohyalinosis, causing fibrinoid necrosis, and from causing these very small Charcot-Bouchard microaneurysms. So we can have deep hemorrhagic strokes, for example, in putamen, most of them. We could have them subcortical and lobar, around 30%, cerebellar area 16%, thalamus, and also pons. So these are actually typical areas where we have hemorrhagic strokes due to uncontrolled hypertension. Small hemorrhages do dissect along the white matter tracts, and large hemorrhagic strokes, they do rupture into parenchyma, they do tissue destruction, and they could do cause raised intracranial pressure. And unfortunately, they could cause death due to the hemisphere or brainstem, with or without brainstem compression. So this is when the large hemorrhages are causing contralateral, so opposite hemisphere compression with midline shift, and unfortunately, this is when the inevitable happens, with all the best care on the ward. So how do they present? Hemorrhagic strokes, they could be actually presenting by any feature of the following, but they are more highly suggested by presentation with headache, with vomiting, and seizure at the onset. Large hemorrhages could cause death or coma within hours, and regardless the location anatomically. Rapid onset, they have a rapid onset, but they could be slow, especially in the presence of the anticoagulant treatment. So what are the clinical presentations? So I just picked up on few locations, for example, putamen, so deep brain. This is middle cerebral artery territory, where the patient is presenting with hemiplegia, so motor deficit, aphasia, loss of speech, also hemianopia, homonymous hemianopia, so visual field loss. We could have eyes deviation away from the affected side. This is typical to putamen. Also thalamus. Thalamus is giving hemisensory, so loss of sensation contralaterally. Also, we could have in dominant, if thalamus is affected in the dominant side, we could have aphasia. In the non-dominant side, we could have neglect. Ocular presentation with downward force deviation, with vertical gaze separation in skew deviation. And we could have ipsilateral Horner syndrome in thalamus hemorrhage. In lobar presentation of the hemorrhage, presentation depends on the lesion side. In cerebellum, it's very unlikely that we'll have coma at the onset. The eyes are deviated always off the away from the hemorrhage, and we can have same side fifth and seventh cranial nerve palsy with ipsilateral Horner syndrome, and yes, brainstem compression could progress into coma. In Pons hemorrhages, we could have total paralysis. Unfortunately, we could go through having rigidity, decerebrating rigidity with extension to pain and pinpoint reactive pupils. So you can see that every single area anatomically is giving us different presentation. So I just wanted to point through a few CT head scans, which are in the first upper line from A to D. You have a left thalamus hemorrhage, which actually is extending. You can see the size. And also in the lower side, what we have a left hemorrhage, which again CT head scan, which is actually increasing in size. Hemorrhages do not tend to increase in size generally. They do progress by regression of the hemorrhage and reduction and resorbing all the blood. So within 4 to 6 weeks after a mild moderate hemorrhage, we shouldn't see any leftover fresh blood. Posterior circulation hemorrhages on the CT, how do they look like? This is quite a large brainstem and cerebellum hemorrhage on a CT scan in this patient. This is the same patient actually. And they are very dangerous. These cases generally are they are referred all hemorrhages to neurosurgical team, but especially cerebellar hemorrhages are taken over by neuroscience centers to be monitored and to intervene if GCS drops or patient is getting worse in any other way. And what is the treatment? I touched base with this already, but as I said, diagnosis is made, definite diagnosis by plain CT head scan. We could do contrast, especially if we have an underlying pathology, especially when we have, for example, patient is under age of 40 with no hypertension history. CT angiogram is required, especially if patient is under age of 40 with absence of hypertension or lobar hemorrhage in under age of 65, which is our practice as well. In amyloid angiopathy, amyloid angiopathy should be explored, especially in elderly patients. We could have presentation of subcortical multiple hemorrhages within occipital parietal lobes. We can have a feature presentation Alzheimer, so association with Alzheimer disease. And they do have quite often 1/3 of these cases progression of dementia. Amyloid disease is diagnosed. We have the Boston criteria, but generally is actually diagnosed by having MRI head scan, a certain sequence in MRI head scan. Medical treatment, so blood pressure control is important apart from the rest, along with the rest. Surgical treatment generally if the hemorrhage is more than 3 centimeters. And diameter, and in young age, we do not, surgical treatment is do not offered, excuse me, especially if the patient is in deep coma, so GCS less than 4, or if the hemorrhage is very small or very minimal lesion. Complications, yes, from disability to hydrocephalus and death. And from prognosis point of view, up to 50% will die within a month. 10% are independent at 1 month, unfortunately just 10%, and 20% by 6 months. So it's a long rehab journey. So what is general prognosis after stroke? Despite of recent advantages in the management of acute stroke, prognosis is quite poor, with up to 20% of patients dying within the first month of the onset of the stroke. It's very important when we are breaking bad news of a large stroke to relatives that we are realistic about the chances of survival and full recovery. And actually, this is the basic, the base of the start point of the discussion with relatives. They do want to know the most often question is how quick they are going to get better and what is the level that they could reach with rehab. So are they going to make recovery and what kind of recovery they'll make? So I just want to outline the examination, the cranial examination, because I think this is where we lack and we can miss actually abnormality, and not just abnormality, but actually we could point where is the lesion, where is the problem. Do you have any questions? Thank you. Was a long presentation, 2 hours.
Yes, I do have a couple of questions, if you don't mind.
Yes, of course I don't. So I'm going to mute my.
So the first question is, if the patient is an anticoagulant or we found that he's newly diagnosed AF, and if he has presented with stroke, I know that we stopped any anticoagulant at all for at least 2 weeks or up to 4 weeks. But what we should do in TIA? Shall we start from the beginning if the patient has a full recovery?
You said few questions. These are your questions.
This
Amir.
is the first one. Second
Yes.
one, if
Oh,
the
okay.
patient
Shall I
presented...
just? Yeah.
Yeah, all right. All right. You can answer this one first.
Shall I just answer, because you asked me 2 questions in one already. So
All right. Okay.
we have different. No, thank you. Are brilliant questions. So if the patient has a TIA, as you said, symptoms fully resolved, and
Yeah,
it's
fully
implying
resolved,
that if there is new atrial fibrillation, is one possibility. Patient should go directly on anticoagulation. Yes. So nowadays we do use DOAC in atrial fibrillation and TIA. So this being said, that this was a TIA presentation, so terminated episode with a normal, so negative CT head scan for hemorrhage. If the patient was on anticoagulation, yes, please, Amir.
And will he be taking like the aspirin and clopidogrel,
Yes.
dual antiplatelet?
No, Amir, no. So very good question. So patient will go straight on anticoagulation with no antiplatelet.
No antiplatelet at all, no aspirin.
No antiplatelet at all if the patient is atrial fibrillation and needs anticoagulating.
All right. Okay. Thank you for clarification.
No problem. If the patient was on anticoagulation and you are in A&E, for example, or you are in acute medicine on call, and patient had a TIA presentation, you are not stopping the anticoagulation. We do want the anticoagulation to continue unless we've seen the patient.
And
so these are the 2 situations.
We're not gonna provide aspirin and clopidogrel?
No. You are just going, no. So in TIA, you are just going to continue either way. Continue the anticoagulation in TIA presentation and let us know about the patient. So again, TIA and AF, we are not giving antiplatelet, we are giving anticoagulation. Right. Now, Amir, you mentioned can I move to the stroke question?
Yeah, of course. Yeah, of course.
Yes, okay. I hope I answered to your question.
Yeah.
Now I'm moving towards DOAC, so anticoagulation, and AF and stroke. So as you know, we have two types of strokes. So we have the ischemic and the hemorrhagic. In ischemic stroke, actually, we do not wait 2 weeks always. So we could, for example, depending on the size and place of the stroke, this is why our practice is a bit different. So the guideline is allowing us to start earlier the anticoagulation. Our practice changed this year compared with how it was before April this year, definitely. So, for example, in a mild stroke, we could start after day 3. In moderate stroke, we could start after day 5, 7. And yes, in large ischemic strokes, we are going to wait 2 weeks. I agree with you, Amir. But it depends on the anatomy of the stroke, so place and size. And in hemorrhage, because in hemorrhagic strokes and AF, this is when we'll stop the anticoagulation, as I said. We are going to reverse it, yes, but we would not give the anticoagulation generally for 1 month. Because as I said in the presentation, this is where we'll rescan the patient, inpatient or outpatient, depending where is the patient, and we'll explore the resolution of the hemorrhage. And of course, depending on the MRI scan, we are going to estimate, future hemorrhages. But sometimes most of the time we can restart the anticoagulation, especially when these strokes are in the in the hypertensive areas. You remember what I said in one of the slides? So all these thalamic strokes, basal ganglia strokes, posterior circulation, so brainstem. So these are hypertensive strokes. So this is when, once the repeated CT is showing resolution of the hemorrhage, we can restart the anticoagulation. In the rest of the hemorrhages, we have to actually wait for resolution because they are longer, they are bigger, larger. 1, 2, we are not so keen to start, for example, to restart within a month if the hemorrhage is very large, isn't it? We'll wait to resolve, and after that we'll rescan the patient and we'll decide. So the anticoagulation, Amir, is not stopped forever, generally,
Okay.
after hemorrhagic stroke. Okay, next questions. You have questions?
Yeah, for ischemic stroke, you said that we can start anticoagulation maybe after 3 days or 2 weeks. Do we need to continue with antiplatelet as well?
No. So once the anticoagulation is started, we don't need antiplatelet.
Okay. All right. And the second question is, if the patient came with a TIA fully resolved and newly diagnosed AF, do I need to do CT scan first before starting anticoagulation, or I can start anticoagulation as long as he's now back to normal?
So I'll tell you what is our practice, and also I'll tell you what is the guideline. So the guideline is saying that if we are convinced that this is a TIA presentation, we can load the patient with antiplatelet straight away. Because we are discussing about the hospital setting. This is where we are, in short, this is where we practice medicine. Because we are in a hospital environment, we do the CT head scan. So it's very handy, it's very useful actually. Is not to diagnose TIA, it's for the differentials, Amir, isn't it? In our practice, this is what we are doing. Now, moving a bit away from, but connected to your question, in community, for example, we have the community referrals from GP, and we do recommend the antiplatelet treatment to be started unless there are red flags, like strong headache, vomiting, loss of consciousness, ongoing symptoms for weeks. in this case, we do tend to recommend to start antiplatelet from community without CT head scan. So in hospital setting, we do the CT head scan for differentials rather than for diagnosis. Thank you. Any other questions?
I just out of curiosity, if the patient presented with acute stroke and within 4.5 hours, does he take, like, he can like go through the thrombolysis and thrombectomy, both of them?
So a thrombolysis definitely, if, as I said, there are no contraindications. So in ideal situation, within 4.5 hours, definitely thrombolysis. About thrombectomy, we do have to have evidence of large vessel occlusion. So we have to have same hemisphere, same side of stroke, clot or, stenosis of the internal carotid artery, the middle cerebral artery, the first, second segment. So this is why I'm saying mechanical thrombectomy treatment is dependent on finding of large vessel occlusion on CT angiogram. So without large vessel occlusion finding on CT angiogram, we cannot offer mechanical thrombectomy. This is based on this finding, the patients are accepted for mechanical thrombectomy in Nottingham. But thrombolysis definitely. So mechanical thrombectomy screening of the patients for this treatment is done by stroke ACP along with the stroke consultant on call.
All right. So if the patient have like large vessel occlusion, so and
yes.
he's in Lincoln now, and he's meeting the criteria for thrombectomy,
yes.
and he doesn't have any contraindication, and he's within window time. He's within the first few hours, 3 hours, let's say.
Yes.
So
yes.
what should we do? Should we do thrombolysis first and then refer him for thrombectomy, or refer him to thrombectomy first?
So this is why we are a team. Thank you, Amir. It's a very good scenario. So patient is going to have thrombolysis, and in the same time, while as you know, thrombolysis has two parts, the bolus, and after that, the 1 hour infusion. So we're not wasting time while the thrombolysis nurse is thrombolyzing the patient. The ACP is referring the patient to Nottingham for thrombectomy. So we are not delaying one for the other. If the patient is actually entitled and the candidate to have both thrombolysis and thrombectomy, we'll act on both, definitely. Just you to know,
right,
the thrombectomy. No problem. Thank you, Amir. Very clever questions. Coming back to the thrombectomy, thrombectomy is a service which is offered Monday to Friday, full days from 8 to 6, but even Saturday and Sunday half day, so mornings at the moment. So Nottingham, they do tend to extend the availability of the service. So they do incline to extend the service to the 24/7 service, like thrombolysis, because we, for example, thrombolysis it's happening just in Lincoln, in Lincolnshire, but actually is a 24/7 service. So it's done day and night, all the time we are screening patients for this. But with thrombectomy is a bit different and difficult in the way that thrombectomy is offered just between 8 and 6 in Nottingham, Monday to Friday, and as I said, Saturday, Sunday, just half days at the moment. It's a lot better than 5, 6, 7 years ago when we started to refer patients from Lincolnshire for thrombectomy, and actually we've been having few days, and after that we extended up to 4 o'clock, and after that now up to 6 o'clock all week. Any other questions?
Thank you so much
for that. If you have any other questions, no, thank you. Yes, If you have any questions, just pop them in the chat, and I'll answer to each of you. Okay. Thank you very much. Thank you. It was a pleasure. Thank you. Bye. Bye. Bye.